And welcome to the Dr. Bob Show. We'll be spending most of this show talking about concussions, about repeated head trauma. Can that lead to brain damage later on, even early Alzheimer's disease? My guest is Dr. Klenck, board-certified orthopedic surgeon, deals with athletic injuries and head trauma. He'll be answering our questions. Hello, I'm Dr. Robert Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about laughter. Is it really the best medicine? Does it really help your immune system? And what's the evidence? You're going to be shocked at how good laughter is. A lot of information for you. You'll want to stay tuned. We're talking with Dr. Klenck, board-certified internal medicine, pediatrics, and sports medicine. And we're talking about repeated head trauma and concussions. Chris, welcome to the Dr. Bob Show. I enjoyed having you so much before. 3 years ago, we talked about concussions, and a lot has happened since then. A lot has been in the news of football players who had repeated injury and have something called CTE. What is CTE?
Well, CTE stands for chronic traumatic encephalopathy.
So encephalopathy would be what?
It's a disorder or a problem with the brain. In CTE specifically, we're looking at a degenerative process, a progressive degenerative process of the brain, which the brain just doesn't function well. It's felt to be due to repetitive head injuries or trauma to the brain that may have happened years and years prior to the presentation of symptoms.
So you can have head injury from 10 years ago or 15 years ago that causes what symptoms with chronic traumatic encephalopathy?
Sure. A lot of people will present with different symptoms, but the common things that people will start to develop over time is issues with judgment, difficulty making judgment, confusion, depression, anxiety, sometimes anger, aggression, or impulse control. It can even lead to full-blown dementia over time.
Yeah, suicide?
Suicide is often cited as a possibility with CTE. And we've seen that reported in the news and the media as well.
So it's a huge thing about trauma at one age leading into some residual problems later on. So let's drop back to younger people. What is a concussion?
Well, a concussion is often called a mild traumatic brain injury. It's where the brain sustains some sort of injury or damage. It may be very slight or subtle. It could be more severe. The ones that we think about are sports-related concussions, where the brain gets some sort of injury that interferes with its ability to function. And it may have many presentations or symptoms that the patient presents with.
How bad trauma does it take?
It's different for everyone. A lot of it involves the mechanism of injury. Certainly, is it a direct blow? Is it a shearing or spinning blow? How much of the brain has been disrupted with that injury? So I think that the impact is different for everyone in terms of eliciting symptoms and concerns.
So what are the symptoms? Let's take a young high school boy who has a head contact in sports, any type of sports, and he gets his bell rung. What are the symptoms that we look for with concussion?
Obviously, there's multiple symptoms. Probably the most common thing that I hear reported is headaches.
What kind of headache?
Everybody describes it a little bit different. Some people describe it as a pressure or just a pressure sensation in their head or a pounding, throbbing headache. Some people describe a migrainous type headache with nausea and visual disturbances. So everybody's a little bit different in how they describe that headache, but it's a pretty common theme in concussion.
Headache, what else?
Dizziness, fogginess, just not kind of feeling right. Some people lose memory or recollection of events prior to the injury. Those are all common findings.
So they have retrograde amnesia,
Correct.
Amnesia before the injury. Is that a worse sign?
There's some studies that suggest that if you have retrograde amnesia, that your recovery may be a little more prolonged than someone who doesn't display that symptom. So it's certainly something that we pay close attention to and consider that in when we're evaluating patients.
Why do you always come and say, how many fingers do I have, and are your pupils dilated? What are we looking for on that?
Yeah, the concussions, what we're looking for is making sure they don't have some sort of structural injury to the brain. You know, one of the things that you don't want to miss in a head injury is a bleed in the brain. You know, did they have enough injury to damage a blood vessel? And if there's a bleeding in the brain, you may see unequal pupils. You may see inability to track lights with the eyes. Those sort of physical exam findings that would suggest that that patient needs more urgent evaluation.
By urgent, you mean what?
An emergency room visit, you know, some
Right
sort of
away.
imaging study. Correct.
There may be a bleed into the brain.
Correct.
If you feel like that's not the case and somebody has just had mild traumatic brain injury, a concussion, how do you know when to let a patient go back into the game, or if you need to keep them out of the game, or what do you do?
Well, I think the day of the injury, certainly probably the most critical point or decision-making process is diagnosing the concussion and making sure that you're not missing something more serious. If you ever have any doubt if a person has a concussion or not, we always keep them out of that participation. So certainly anyone who has symptoms or signs of a concussion should never return to play on the same day of that injury.
But the athlete or the person that was hit on the head, he doesn't want to let his team down. He wants to, I'm all right, coach, let me in there. And they sometimes make improper decisions, the athlete, and not listening to the coach or the trainer. Is that common?
It certainly happens. I think it's incumbent upon the athletic trainer or the team physician to not allow that to happen. If a concussion is identified, certainly we remove the patient or the athlete from the game. We often, for example, in the sport of football, will take their helmet away so that they can't go back into the game. We do those kind of things just to prevent the emotions of the game from overtaking the common sense that should prevail.
Can that happen in midget football or elementary school or junior high school athletics, and not just football? I think I make a mistake if I say just football.
Right. Well, certainly soccer is one of those sports that we're seeing more and more concussions.
Why soccer?
Well, there's such a contact collision nature to soccer, including running into other players and heading the ball and hitting the ball with the head. And they don't have the protective equipment that the other sports like football and rugby have, where they may have more equipment to protect themselves. So we're seeing a trend in soccer.
I've heard one of the most common things in soccer is, since they're heading the ball, if two different people go up trying to head the ball, they hit their head instead of the ball.
Sure.
Is that a common avenue of getting a concussion?
Absolutely, yeah. Any sort of collision injury can result in a concussion, and the unfortunate part of that, you often have two concussions instead of one when two players collide. So those are certainly things that we watch for, or mechanisms that we consider as potentially dangerous.
So soccer, football, basketball, do you have head injuries?
Basketball, we do. We see head injuries in basketball, not probably in the number that we see in some of the other sports, but certainly people taking charges, hitting the ground, head on the ground, those sort of things are not uncommon for us to deal with.
A basketball floor is a little bit harder than a football field, and so you certainly get a lot of people with injuries that way.
That is correct.
Is it important to have a protocol on how to handle people that have had concussion, and how do you know to tell the patient how they can recover?
Sure. I think it's imperative that you have a protocol with which you follow to make sure that person returns to play safely.
And that's what we're going to be talking about when we come back. We're going to be talking about, what is the protocol? How do you know when you can return to injury? What kind of activity is harmful to the brain? We'll be answering those questions when we come back. We're talking with Dr. Chris Klenck, board certified internal medicine and pediatrics and sports medicine. We're talking about concussions and how concussions occur with symptoms of headache and confusion and amnesia. Some of those are easy to diagnose, but some of those are very, very difficult. And so if somebody is diagnosed as having a concussion, what do we do? Chris, what do we do? If an athlete wants to go back in the game, you think he has a concussion, you keep him out of the game. What do you do as far as deciding how to return to the game that day or next week or 8 weeks.
Sure, sure. Well, certainly, like we mentioned before, if you have a concussion on the day of game, you should never return to play. Even if you're not sure, you're considering that as a possibility, you should err on the side of caution and not return to play, because the risk of recurrent injuries, particularly on the day of an injury, is very high.
So a stitch in time saves 9, meaning if you're even questioned, you just say, sorry, you can't go back in, you take the helmet away, and then what do you do? Because he's heartbroken.
Yeah, yeah. And it's one of those things that it's sometimes hard to explain to the student athlete and the coaching staff as well. But I think the recognition of concussions and the importance that we placed on it, I think people are beginning to understand that and are more accepting of being a little conservative, being a little cautious in making sure that you protect your athletes.
So let's talk about the next 24 hours or the next 48 hours. What are you looking for?
Yeah, we keep a close eye on them over the first several hours after the injury, just to make sure that their symptoms don't progress, worsen, or become more severe. Certainly, if any of those things happen, then we often do a more urgent evaluation, perhaps at the hospital or emergency room. Most people don't have that problem. Most people do quite well, and then we monitor their symptoms in a progressive fashion. The first step is really to allow their symptoms to resolve at rest.
At rest?
Correct.
What do you mean by rest?
Well,
in the bed?
Well, not necessarily in the bed. No, we allow them to go to school. We allow them to be active. We don't allow them to do heavy workouts. Certainly don't allow them to practice or play their sport. We allow them to just be a normal individual.
If you rest the brain, does that mean you can't watch television, you can't play Xbox or the other games and this and that?
Certainly. That certainly can contribute to your symptoms. Any sort of visual stimuli that produces your symptoms or aggravates your symptoms, makes your headaches worse, your dizziness worse, we ask them not to do that. Not only does it make them feel bad, but it's also delaying their recovery. Again, anything that exacerbates symptoms, we want to minimize or restrict. And that may include even going to school. You know, I've held student athletes out of school just because trying to concentrate and listen to the lectures can be provoking of their symptoms. So a short period of rest from school may even be indicated.
At a younger age, well, let's say a child who's 11 years of age and they are knocked unconscious and they come out and they're fine and they've got a little headache the next day. At a real young age, is it a time to say, let's wait till next year, or is it okay to follow them under a protocol of rest?
I think that you can follow them under a protocol of rest. I don't think you have to keep that individual out for the rest of the year. Although I am very cautious or careful with the younger age kids, only because they still have developing brains and they are sometimes at a higher risk or have more prolonged recovery than someone who is a professional athlete or a college athlete who's 20 or 22 years old.
So back to the college athlete. You've had him rest, you've had him stay away from brain stimulation. Then what do you do?
Once they feel like their symptoms have resolved or they're feeling really good and back to normal, then we do an exertional progression. So we have a very outlined protocol in terms of having them do some biking, some sprinting, some running back and forth, and maybe even some sport-specific drills. For example, a receiver may run pass routes and catch a ball. We're monitoring them every step of the way to make sure that activity doesn't reintroduce or reprovoke their symptoms.
So what are you looking for? What kind of symptoms, if you're on that recovery stage, just running down the field, catching a ball without any contact or anything?
Yeah,
what are you looking for?
Well, we're observing them in terms of, are they missing passes? Are they not remembering the pass route that they were given? You know, are they having trouble recognizing the things that they need to do? And then again, as we mentioned before, it's very subjective, so we'll stop the athlete after the activity and say, how did that make you feel? What did you sense? How does your head feel? How does your sensation feel, your vision? Those sort of cues.
Do you have any written tests that you take before the season that you can compare thinking ability later on?
Absolutely. We call those cognitive evaluations. And before the season starts, we do two cognitive evaluations. One is sort of a quick paper and pencil type of test that we ask the students to fill out with us. We walk them through that. So we have a day of injury cognitive evaluation. So we know kind of what they're thinking and how they're processing information. Then we have a more detailed computerized version of that test that asks for memory, visual memory, verbal memory, reaction time, speed of answering questions. That gives us a little more comprehensive view so that we can use that test prior to return to play to make sure cognitively they're back to baseline.
Do most people cognitively at a college level return fairly quickly, or not. That's exciting. You're getting very sophisticated.
Yeah. Well, in my experience has been that most of our student athletes at the college level do recover relatively quickly. If you look at the averages based on the studies, an average return to play time is about 7 to 10 days. The younger student athletes and sometimes the female student athletes take a little bit longer to recover than some of the more seasoned athletes. Again, everybody's different, and certainly factors like prior concussion injuries may play a part in that, the mechanism of injury. But on average, I think most of our student athletes in the collegiate level do pretty well. They recover a little quicker than some of the younger athletes.
So when headaches are gone, confusion's gone, amnesia's gone, thinking is good, testing is good, they're feeling good, how do you gradually put them into contact?
Right. It's one of those things that each one of those things that you just outlined are little pieces of information that we collect and put together to make our final decision. In addition to the computerized testing that we talk about. Once we feel like that individual is back to a baseline, back to where we feel good about their status, then we usually introduce a non-contact practice. So we have them kind of do a little bit of bumping of pads and that sort, not allowing people to tackle them or hit them, but bumping of pads and monitoring their activities that way. If they do well with that, then we allow them to return to contact. So it's, again, a stepwise progression, and each piece of information each day is important in making those decisions.
If we drop back to midget football now, and people are getting bigger, faster, there's more problems with coaches wanting their children, their young players, to be aggressive and to hit harder and to knock that guy down. Should we be limiting physical head contact at younger ages, or do we have better helmets, or what are we doing to protect younger athletes?
Sure, I think there's a lot of discussion about that now publicly, and a lot of research is being invested into younger athletes. I think there are some guidelines now in which we're trying to limit a lot of the head-to-head collisions and contact activities with our young student athletes. I think that's very important. I think we do need to limit the number of head exposures or contact exposures for the younger athletes. I don't think that we have to outlaw football or ban football for youth sports. I think we have to be smarter about it. I think we have to make sure we have updated equipment, that our helmets aren't old or falling apart, that we're being smart about how much contact they get and teaching them the proper ways to play football, tackling, or soccer. You know, we limit how much heading they do and teaching them the proper ways to play the sport.
Are they making better helmets?
I think they clearly are. If you look at the helmet industry, I think there's a new helmet that comes out almost all the time, and evaluating those helmets can be somewhat tricky. But I think if you pick a helmet that's been evaluated by the NOSCI, the certifying board who evaluates helmets, I think you're going to be in good shape. There's a lot of great helmets. No helmet's concussion proof. No helmet's going to prevent you from having a concussion, but there's several helmets that will help reduce your risk and allow you to play and have a relatively safe time.
So what I'm hearing is we're getting better and better at diagnosing. We're getting better and better at knowing when to allow people to go back, that there is a real impetus on young people to make sure that they don't have repetitive head injuries. And if they do, they need to be sure that it's properly evaluated. If that doesn't happen and somebody has repeated head injuries, can it lead to chronic traumatic encephalopathy later on?
Sure, that's a great question. I think the most important thing you said in that entire scenario was the making sure they're evaluated. You want them to be evaluated by somebody who understands concussions and knows concussions and has the right mindset in terms of return to play. Now, with respect to CTE or the development of CTE, you know, I think the jury's still out on that. Certainly, there's several professional football players who've had many contacts and have zero symptoms or zero signs of CTE, and then there's the group of people who do. And what differentiates that group, who's at risk for CTE and who's not, I don't know that we know the answer to that, and I think time will tell. But logic would say is the more trauma you have to the brain, the higher risk you're going to have of potentially having problems later in life.
And Chris, what I'm hearing you say is, we love our children, we love our athletes, we love young people, let's take care of them. Thank you so much for coming to the Dr. Bob Show.
Welcome.
This has been so informative, and thank you.
Thank you.
And you're going to want to stay tuned. We're going to be talking about laughter. Can that help the brain? Can that help your immune system? It really can. So you're going to want to stay tuned and see why laughter is the best medicine of all. I want to thank Dr. Chris Klenck. Wonderful discussion on repeated head trauma. Be careful, take care of your children. And now for questions from you, the viewers, that I think will be important to your health. And this is a great one that I love. Dr. Bob, how does laughter really improve health? Well, you know, that's a good question. Laughter is the best medicine. We hear that, but what is the science behind that? Is there any science that says laughter indeed helps people? So let's talk about that, because every week we talk about, most of all, what do we like? Is that laughter in your life? Well, what does laughter do? Laughter does help the immune system. And studies are now beginning to show that in the immune system, there are some cancer protective cells. They're called natural killer cells. And when people laugh a lot, when they're happy, just for an hour, the natural killer cells will become more active, and they search out abnormal proteins in the body like cancer that starts early, that it can actually neutralize. Very, very important that in the treatment of cancer, that we don't use doom and gloom. That can make us worse. Let's really increase those natural killer cells. The other thing that laughter does in the immune system, there are cells called T helper cells. The helper cells come from a cell called a lymphocyte, and those helper cells produce immunoglobulins blocking antibodies. Pretty sophisticated. Well, what it says is laughter makes it where the antibodies that neutralize infection are also increased. So we've got cancer fighters with laughter. We've got immunoglobulins with laughter. So it helps the immune system. Laughter will produce a substance in the lining of the heart called epithelial growth factor that protects the lining of the heart. So it protects the lining of the heart also and makes it more difficult to have a heart attack. It doesn't make it where you won't have one, but it decreases the incidence of heart attacks. We know that laughter makes the muscles relax. It actually decreases pain. So when we're looking at pain fibers and we're testing those, we see that laughter indeed just by itself will diminish pain. So while we're laughing, it will make it where things don't hurt us as much, or it will protect us if we've got a painful injury or a painful illness. So laughter is so important. It helps us socially. So we know that socially, that laughter makes people do well with each other. It cuts down on anxiety. It increases a chemical in the brain called endorphins that make a runner high, that makes people feel good. And when you laugh and you feel good, people around you feel better. And so it's important socially, for social interactions, to get together with people. People are attracted to somebody that's laughing. There are so many things that laughter will do. Laughter, when it produces the endorphins from the midbrain, cuts down on depression. So we don't get depressed. We don't feel bad. Our muscles don't get tight. We're not anxious. We're not nervous. Our blood pressure with muscles relaxing. We protect our heart, less heart attacks. So is laughter a good medicine? You better betcha. What can we do to improve laughter, and what can we do to laugh more? Go to a funny movie. Find somebody socially. Be sure that you get together with a group. Play cards, do something together where you laugh and tell stories. When you do that, remember, your immune system will work better. Your heart will be protected. You'll have less anxiety. Read funny books. Read the comic books. I love to read the comic strips in the morning, especially the Family Circus. I can just laugh my head off when I see that. That protects me, and I'm going to live longer because of it. So know that indeed laughter is the best medicine and it will help you significantly. That's all the time that we have for this show. Remember, what exercise does, probably the most important thing that we can do. Exercise decreases stress. Exercise reduces blood pressure. Exercise helps us keep the weight that we want. Exercise will also help protect the heart. Exercise will produce collateral circulation in the heart. So people that exercise on a regular basis with a Fitbit that encourages people to walk, with the gym and with activities at a health club where we're encouraged to exercise. Remember, don't let exercise be neglected in your life. Eat properly, eat good food, keep your weight down, eat more fruits and vegetables. Vegetables with antioxidants will help your brain, will help prevent Alzheimer's. Get your 7.5 hours of sleep. If you get 7.5 hours of sleep, it'll make you happier. You'll feel better. People around you will feel better. It will be one of the best things you do. If you can't sleep well, know that you need to work out with your doctor, and we'll go back to laughter. It indeed is the best medicine. Stay healthy.